There are thousands of people out there. You are one of them, suffering in pain with nowhere to turn and no one to get help from. And so whilst, again, this is not medical advice, we will answer some of your questions. We're going to give opinions, we're going to give thoughts, we're going to give views, and this may guide you in some way to get some answers you're looking for and ultimately the help that you need. This was from Dana Marie, and she said, "Thank you very much for doing a great job of CRPS overview. The downside is this interview mostly discusses and shows images of CRPS in the limbs. I have CRPS in my abdomen and pelvis due to chemotherapy and a trauma gallbladder remover and a hemorrhagic ovarian cyst. No one ever discusses the rarity but the horrible reality of how you can literally develop CRPS anywhere." Can you develop CRPS anywhere?
Absolutely.
How do you diagnose it?
Well, when it's in the hands and the limbs, it's easy because it fits in with our common paradigm. But I've absolutely seen CRPS in the abdomen. I've seen CRPS of the genitalia. I've seen CRPS of the face. And it falls into recognizing those classic Budapest criteria that we use as doctors, which is a clinical examination.
Yeah.
Is there erythema? Is there swelling? Is there allodynia? Is there hyperpathia? I'm using all of the doctor words now.
Fine.
But what these signs and symptoms are classical for are these neuropathic pain conditions with the autonomic nervous system lending credence to this being CRPS.
So do you have to have CRPS do you have to see it to diagnose it? Because that's what I say, you've got to see the warmth, the swelling, the skin changes, the nail changes. That's not acute CRPS, but you've got to see the red hot swollen foot or hand or knee.
Ideally, yes, because it makes it easier for the clinician because these are our markers. But patients sometimes come to you with a clear history. Yeah, I had the swelling, I had the color changes, but they've died down now. And now I'm just left with this neuropathic pain. And we know that CRPS evolves into that. So it depends on what time point you're seeing the patient. And the problem with some of these atypical areas is you won't see them acutely because, they'll see them. Maybe if you've got a good doc, he'll say, well, is this a skin infection? Let's treat you with some antibiotics. Oh, it's not getting better. Let's do some swabs. Oh, the swabs are all negative. Another extended round of antibiotics. Then you're obviously seeing them at a much later point in time when they've seen the infectious disease person or back at the GP again where these problems are occurring and it's not going away.
Here's a case report published in 2021. Truncal complex regional pain syndrome, myth or reality, a case report. And they're only case reports. This is not something that's going to be studied widely. CRPS can occur in the trunk and not only limbs as previously thought. CRPS can occur after an appendectomy and surgeons must be wary. Early diagnosis and treatment are essential for outcome. So as Marie said, she had chemotherapy, she had a trauma gallbladder removal and a hemorrhagic ovarian cyst, and it sounds like no one's really been able to diagnose this. And I would find it quite hard to diagnose a CRPS. So how would the treatment be different from CRPS and just good old-fashioned neuropathic pain?
The problem with CRPS is getting it in the acute phase. If you can get it in the acute phase, there's a 30% remission rate from CRPS.
Yeah.
I think that's the key with CRPS, getting it early, treating it with an appropriate analgesic regime, including something to help with some of the immunomodulation, which is dampening down the immune system. You increase the chances of that patient being that 30%. This is going to then quieten down and stay at a low level. And it's missing that acute diagnosis, which then makes it much more difficult to treat later. With regards to treating it later, it follows pretty much the same paradigm of treating neuropathic pain. Okay. So I don't think there's going to be all that much difference when you treat it later. It's just getting good outcomes later in CRPS becomes much more difficult to achieve.
Okay.
And that's because the CRPS, especially if it's not adequately treated and controlled, then tends to do this awful thing of spreading. And what we know from functional MRI scans is that you start to get changes within the cortex of the somatosensory cortex, where you'll get cross-linking of areas, which means that that spreading can then go from, say, a small element over the gallbladder or the belly button, and then extend out to half of the abdomen, and then can start mirroring on the other side of the abdomen. And so it's getting the patient in, getting the pain controlled, and getting them on appropriate treatment.
So one of the questions was, and you and I have treated CRPS a lot over the years, one of the questions was, please explore the difference, or please talk about how DRG devices and spinal cord stimulators can help. And that's a touchy subject.
It is a touchy subject.
What are your thoughts?
Look, spinal cord stimulation absolutely can help in CRPS. I think they all can help in CRPS, whether it's DRG or traditional dorsal column spinal cord stimulation. There's a lot of people who are naysayers in the field about neuromodulation therapy, but and saying that there's no evidence, but that's not quite true. There is a wealth of evidence of papers in the use of spinal cord stimulator in CRPS. It's part of the NICE guidelines, and so NICE guidelines don't specifically say CRPS. They say spinal cord stimulators are treated for neuropathic pain, and CRPS is a neuropathic pain.
Definitely a neuropathic pain.
And so it's absolutely indicated in this condition. And we have some good studies out there showing that patients can achieve high quality pain relief with these devices. Not all patients, and we know that spinal cord stimulators will not be appropriate for some patients. There's indications or there's risk factors where they don't work. So where there's untreated psychopathology, patients who are on high dose opioids, and so we use a limit, and this is based on the studies of 90 morphine equivalents. Once you get over 90 morphine equivalents, spinal cord stimulation is not going to be appropriate for those patients because you're not going to get the therapy. Smokers as well fail spinal cord stimulation. So I think those are the three big things that, you why go down that route if you haven't addressed those basic lifestyle medication issues and the mental health issues.
That's fair enough. Whenever we talk about advanced pain therapy for a patient, whilst we say these are the stories, these are the positive outcomes we've seen, I can remember the first one I ever put in was for CRPS of the hand. And it was a low frequency system, which is another discussion. We can talk about that at some point. But over the course of the subsequent 4 years, the first year she weaned herself off opioids. The second year she got back to driving. The third year she got back to work. And the fourth year we turned it off for 6 months because she wanted it out. She didn't need it anymore. And after 6 months of no pain returning, we just took it out. And it was completely life-saving. She still had the contractures of CRPS, and I know I've told you this before, but her hand worked and it wasn't painful. So whilst we know it's going to be helpful, and we're very good at doing it because we are versed at it, trained at it, what are the risks? You're going to tell a patient, I'd like to consider this therapy, but whilst we have to say these are the potential benefits, these are the potential risks. What are the potential risks?
So the potential risks, as with any medical procedure, because I don't think there's any medical procedure that is 100% risk-free.
Yeah.
Whether it's, a vaccination, a medication, or doing some of these interventional procedures. Specific to spinal cord stimulators, what we're planning to do is introduce a needle into the epidural space. Just for the context to the viewers, myself and Nick, we're anaesthetists, so we're not spinal surgeons. Spinal surgeons will do this in a different method. And so what we tend to do is using a needle technique. We introduce a needle into the epidural space. That comes with its own risk factors. So whenever we put a needle into the epidural space, it's a potential spinal space. we can damage the spinal cord, obviously, which is an extremely rare event.
Yeah.
We can cause a tearing along the lining of the spinal cord, which can cause a severe headache. And then there is a theoretical risk of us introducing infection into the spinal cord or developing a blood clot in the spinal cord. Again, these are very rare events. If you look at the literature, they're quoted anywhere between 1 in 100,000 to 1 in 150,000 chance of some of these rare but catastrophic things happening.
I've been doing it for more than 10 or 12 years now. Touch wood, I've never had a rare or catastrophic event. I have had infection. I've had to remove a couple of devices because they've become infected. That is a risk factor. There are reasons for that as well. But like anything, if you prepare the patient, if expectations are appropriate, if you are well practiced in what you do, if you have the right systems to help diagnose early and manage, it generally is a safe procedure.
Absolutely. And look, the infection rate is low. The quoted infection rate is around between 1 to 3%.
Yeah.
Depending on what literature you're looking at.
Yeah.
And if you try and do the best for the patient, utilize meticulous surgical technique, have them on some prophylactic antibiotics, you can try and minimize that. Unfortunately, it's never going to be zero for infection. And then there's also device-related complications as well. So although we try and be meticulous, place the leads, we secure them in place with anchors, there's always a risk of a lead moving.
Yeah.
That risk drops down after 12 weeks significantly, but it can happen later. And then there's a risk of a lead fracturing or something going wrong with the battery device, which is very rare. And so you can have a hardware failure at some point.
Yeah, we've had some people where the recharging of the device, which happens through the skin, is uncomfortable, and that can be one of the things that leads to pain over the battery. And there are ways that we diagnose and treat that as well. So the big four that I tell patients, again, you tell patients about good, but you tell patients about risks because it's always a balance. You always tell patients about what would happen if we do nothing, because doing nothing is clearly an option as well. The big four are lead migration, which doesn't generally occur now we've got our techniques right. Pain over the battery site. Infection is a risk, as we've touched on. And the other one is sometimes therapy can wane over time, but the way the devices are changing, that is less likely to occur. I hope that's answered Danny's question.
She had one other
What
part
was
of
that?
Question. She was asking about DRG stimulation,
Correct.
which is the dorsal root
Marine.
ganglion,
Yep.
versus traditional dorsal column spinal stimulation.
Correct.
And it's a bone of contention. We've just come back from our annual scientific meeting where actually this topic was discussed. And if you look at some of the papers, they seem to suggest that they get slightly better effects from DRG stimulation. And other papers seem to suggest that actually dorsal column, you may get some better sympathetic responses from stimulating the dorsal column. I think both therapies are appropriate. DRG seems to be for more focal neuropathic pains, and where you'd consider a DRG system. It has its own issues associated with DRG stimulation as well, and you may not get as good coverage if you do the dorsal column for some distant focal pain. If you do a dorsal column system, there's even papers out there suggesting the combination of both a DRG system combined with a dorsal column system.
Okay.
So I don't think one is overly superior to the other. It's what is getting the patient the best outcome.
Yeah.
And sometimes it's, you may need to try one system and see if that is giving you suitable relief. What are your thoughts, Nick?
DRG can be done. It's a little more fiddly to do. But again, the technology, the hardware is improving all the time. And I've clearly used both. And it depends on the person sitting in front of you because everyone's different. Every pain is different. Every situation is different. And it's got to be balanced out with everything, including doing nothing, changing lifestyle, all the way to advanced pain surgeries. One of the things we did forget to say is this is an opinion of two medical practitioners. We are not giving medical advice. We are having a discussion, and hopefully we're giving Marie some answers to her questions.
And add a bit of context to that question as well. So
correct.
I don't think both myself or Nick, we've covered every single aspect because we're just given a quick 5-minute discussion, but this is just a very basic overview from what our practice is based on.
Good. So let's do another question.
Okay.
And then you've got to get your day started. This is from Jason R. Or Jason Romo, 1947. I've had chronic thoracic pain, which I'm pretty sure is neurological, every day, never ending for the past 3 years. It doesn't get better when laying down or standing up. I'm coming to an end soon. I'm only 20 years old and I don't want to deal with this pain anymore. I cannot. I've been strong. I will not live my life like this. I'd rather not be here.
Oh my gosh.
What are your thoughts for Jason?
20
years old, chronic thoracic pain, neurological, every day, never ending for 3 years.
As you seek appropriate help at this time. So, first protocol was, have you seen your GP? He's obviously going through a lot of emotional and psychological distress. He feels that this is how his pain is always going to be. And I just want to get him the support and help that he needs, because I think he needs multiple levels of support just from that message that he's sending across to us. So please reach out to your GP. Please see a chronic pain specialist. I don't know what his underlying condition is, so he may need some investigations. There's absolutely treatments that we can look at to try and help your condition. So it all starts with a conversation. And what I'd say is reach out to your local healthcare professional. They'll know where a network is available for you, wherever Jason is based. And let's see if we can do something to support you a bit more and help you on this journey.
So he's 20 years old, he's got thoracic pain. He says every day. And one of the things that comes to my mind is, was there a trigger? An injury?
Was there a trauma?
A trauma?
Was there a surgery?
A surgery, something.
An
Sometimes
infection?
Sometimes it doesn't happen, and sometimes it just happens.
Spontaneous.
But he's 20 years old. He sounds pretty socially isolated, and it's there all the time. And because it's there all the time, is this a neuropathic pain? Is there a neuropathic component to the pain? What was the trigger of this neuropathic pain? Possibly. So, like you've said, the best thing to do is get help. If you don't know how, see a family practitioner, see a doctor. If you're not sure, go online. In Australia, there are things like Beyond Blue, which can be supportive. You just pick up the phone and phone them. A lot of our audience are from either Australia or the UK. So if it's the UK, not the UK, the USA, there must be a similar thing overseas that you can reach out to. But it sounds like he does need to get help, and it starts with finding somebody that can plug him into the right team.
And I really feel sorry for this chap, because the neuropathic pain component is always so much more distressing than joint pain or focal pain. And he's 20, he's just starting out, he's probably dropped out of education. It sounds like it's been going on for a while as well.
3 years, yeah.
Losing your social network, losing your self-identity and your self-worth.
Yeah.
It's catastrophic.
Yeah. All right. Jason, let us know how you're getting on, and we'll do our best to reach out to you.
And please update us.
Will do.